Good morning. I'm Dr. Chad Vercio, the chair of pediatrics here at Riverside University Health System. And we're excited to bring you this morning kind of a review of some of the major articles that have come out on COVID over the last few months. There has been a flurry of literature. It's been difficult to keep up with. And so we're going to take a little bit of time this morning to cover some of the studies that we felt like were important studies for people to be aware of. We're lucky to have with us Dr. Walter Klein, who's one of the medical ICU attendings here at RUHS, and Dr. Jeff Leung, who is our medical director for the community health centers and has been heavily involved with the modeling and everything around COVID. We'll start really quick with a regional report. I don't know, Dr. Leung, if you want to cover kind of the Riverside County statistics.
Thank you. I don't have them pulled up, Dr. Vercio, but I can say that, our doubling time is over a month. We've seen a slight uptick recently in the new cases over the past 2 to 3 weeks that we think is likely related to the reopening, as well as, a push with the testing. And we also do see some impact with our hospitalization capacity, likely related to, a tiny bit related to Imperial County, as well as some of our inmates across the county and state. So those are some things that we're seeing, and we're watching that positivity threshold closely because we'd like to keep that below 8%. Thank you.
Yeah, so currently we have hospitalized 220 across the county. With 71 in the ICU. Both of those are up just a little bit from where they dropped down to a few weeks ago. And then there's a total of 365 deaths across the county. For San Bernardino County, their doubling time is about 17 days, so they are increasing more rapidly than Riverside County. They've had 221 deaths as they were a little bit further behind in their outbreak. They have a positivity rate currently of about 8.2%. Their ICU census has increased. They have 72 ICU patients across the county, and their total hospital census, they have 164 COVID positive patients. So now after we've reviewed the kind of regional statistics, we'll move into the articles that have come out. And I wanted to start with one that was kind of controversial. This is really, and ended up being a retraction from a pretty major journal. So this is The Lancet, and it was a retraction of an article on hydroxychloroquine that compared hydroxychloroquine and chloroquine with or without a macrolide for the treatment of COVID-19. It was supposedly a multinational registry analysis. And I didn't want to, it was one of the articles that was pointing to hydroxychloroquine not being helpful and potentially being harmful, and contributed to kind of the shift in practice, but was retracted from The Lancet. And that I wanted to cover why primarily. If you read the retraction notice on the Lancet's website, it was actually written by a couple of the other authors. And it was based on some critiques that had been sent in on the veracity of the data and the analysis conducted by Surgisphere Corporation and its founder, who was one of the co-authors of the publication. So there were some questions as far as the hospitals that were included, the severity of cases, and that kind of thing. Unfortunately, none of this at this point will be known as far as whether it's valid or not. Grateful that those who are critiquing the study raise these questions, and it's important that everything be questioned as these studies come out. And this one highlights probably why. But unfortunately, Surgisphere would not transfer their full data set or client contracts because they felt it would violate the client agreements and confidentiality requirements. There couldn't be any independent or private peer review, and so they had to be withdrawn from the peer review process. So we don't really know how valid the data was or wasn't. because of that, which is a bit disappointing. Now, there's a fair amount of other data on hydroxychloroquine that seems to suggest it's not helpful. There's a recovery trial which was done in the UK. There's somebody that's quite noisy. So if you're not specifically speaking or have a question, if you could mute, that would be very helpful. So the recovery trial was done in the UK. There were 1,500 patients that were randomized to hydroxychloroquine and 3,000 patients that were randomized to usual care. There was no difference in a 28-day mortality rate, with 26% in the hydroxychloroquine group and 24% in the usual care group dying. And they didn't note any other effects on hospital stay duration or other types of outcomes. So this has actually not been published in a paper so far, but it was something that they released as part of their trial, and they closed down the trial because of the no significant results between the two. So that and other studies seem to suggest that really hydroxychloroquine doesn't seem to be helpful for those patients that have been hospitalized for COVID. But the question also remains: do less symptomatic patients or patients early in their disease progression, would they benefit from hydroxychloroquine? And so I wanted to highlight another study that looked at that specifically. And I will say that this is probably not powered adequately to fully address the question, because we know that most people with COVID will do quite well. And so it's only, a relatively small percentage that will actually get ill or severely ill. And so you would need to treat a lot of people to prevent, people from going on to have that disease, that severe disease. So this trial was done in the US and Canada, and it was a randomized, double-blind, placebo-controlled, so kind of the gold standard for if you're going to do a trial. And they randomized 821 asymptomatic participants who either had a high-risk exposure or a moderate risk exposure with somebody with the virus. And then it followed them for 14 days to determine their likelihood of, or determine whether they were diagnosed with COVID or developed symptoms related to COVID. And so and they got treated within 4 days of this exposure, either with placebo or hydroxychloroquine. So there was really no difference in the rates of new illness. 11.8% of the hydroxychloroquine group and 14.3% of the placebo group developed the illness. The p-value for this was 0.35. So those of you that haven't read a study for a while, p-values are essentially telling us the likelihood that the outcomes of the study occurred due to chance. And so a p-value of 0.35 would essentially say that there was a 35% likelihood that the results of the study occurred by chance, which is too high to say that that would be statistically significant. Most we, or in general, consider statistical significance as a p-value of 0.05, which would be a 5% likelihood of the results occurring by chance. There are situations where you may accept a higher p-value that would have clinical significance than a p-value of 0.05. But and in this study, there was no deaths. There was only one hospitalization per group. So it suggests that maybe there's not a benefit. I will say that, in my mind, the jury is still out on that issue, but this seems to add a little bit of evidence that hydroxychloroquine is not necessarily helpful. So I want to turn it over to Dr. Klein. He's going to highlight or discuss an article on remdesivir, and so I wanted to turn it over to him to hear from him on that. We can't hear you.
There we go. Can you hear me now?
Yes.
All right. Good morning, everyone. I wanted to review the preliminary data from the NIH-funded study on remdesivir, which is a RNA polymerase inhibitor that was shown to be moderately effective in SARS-CoV and MERS-CoV. And early data also showed that there was in vitro inhibition of SARS-CoV-2 back in January and February. And so this was a NIH-funded study looking at adults hospitalized with COVID pneumonia. And this was a double-blinded, randomized placebo-controlled trial comparing a 10-day course of remdesivir to placebo. And this trial enrolled 1,063 patients at 60 different study sites around the world. It was predominantly in the United States. There was one study site in Mexico, as well as several in Europe and several in Asia. The primary endpoint of the study was to look at clinical improvement with remdesivir. And they were basically assessing the patients clinically for the first 28 days of enrollment, and also looking for any adverse events associated with remdesivir. And they stratified the patients on what they called an ordinal scale with 8 different categories. With category 1 being discharged to home with no functional limitations, all the way up to category 8, which would be in-hospital death. And they defined clinical improvement in categories 1, 2, and 3. Again, 1 being where you were home, off oxygen, without any limitations in activities. Category 2 being discharged to home with functional limitation, or on supplemental oxygen. And then finally, category 3, where you remained hospitalized, but were no longer receiving treatment for COVID and not on supplemental oxygen, but were being held in the hospital for infection control issues. So in this study, they basically assessed about 1,100 patients for randomization, and ultimately randomized the 1,063 patients in the trial. And looking at the demographics of this study, the average age of enrollment in this study was 59 years of age. About 2/3 of the patients were male. They had a very good racial diversity in the study, with about 1/4 of the patients being Hispanic, 20% of the patients being African American, about 13% being Asian, and the remainder white. They looked at comorbidities specifically, and they found about 90% of the patients in the study had a comorbidity of either hypertension, type 2 diabetes, or obesity. And again, all of these patients were hospitalized. The vast majority, about 90% of the patients, were at a minimum requiring supplemental oxygen, all the way up to mechanical ventilation or requiring ECMO. And in that final group, about 1/4 of the patients, it should be noted, were requiring mechanical ventilation at enrollment. And the key take-home from this study was that remdesivir shortened duration of clinical symptoms. Again, with patients being in those first 3 categories, either discharged to home or remaining in the hospital but no longer requiring oxygen or medical care for COVID-19 pneumonia. The patients receiving remdesivir achieved clinical improvement by 11 days. The group in the placebo arm achieved clinical improvement at 15 days. Now, they did do secondary endpoints in this study, and it is important to note that The remdesivir group did also have a lower mortality at 7.1% compared to about 12% in the placebo group. Unfortunately, the study wasn't large enough to show that this was statistically significant. And so, the take-home points when they, kind of look further at who was most likely to benefit from remdesivir, it appeared that the patients who were admitted to the hospital and only required supplemental oxygen via a simple nasal cannula seemed to have the best response to remdesivir. The patients who were on high flow oxygen, non-invasive ventilation, or certainly invasive ventilation on the ventilator tended to not show as much improvement with remdesivir compared to the patients with a lower severity of illness. So I think, the take-home points from this study, this is a promising study. And again, this is preliminary data from the study. They published this data, on their, initial unblinding of the data. And there will be further publications later on, I believe, from this data set. But the take-home points appear to be that remdesivir is effective in this randomized double-blind placebo-controlled trial, certainly with earlier resolution of symptoms. And they're, I think, in a larger trial, likely would probably see a trend towards improved mortality.
Thank you, Dr. Klein. Yeah, it will be really interesting to see. It didn't seem like they'd looked at, the different causes of mortality, because as everybody's aware, that there are different causes of mortality with COVID. And so will remdesivir affect those different causes of mortality differently? I want to turn to another study. This one is, and just for those of you that are on the call, you can see these studies in the chat. I put the titles with the authors into the chat or box so that you can see that. So I wanted to highlight a study. This one came from China, and it's the clinical characteristics and outcomes of patients with severe COVID-19 with diabetes. And they looked at 193 patients with severe COVID-19. Now, it was a little interesting to me how they defined severe, because some of it was based on the respiratory rate, which to me wouldn't necessarily suggest the severity. But if the patient had a respiratory rate greater than 30, oxygen saturation less than 93, PA to FiO2 ratio of less than 300, or if they were in shock or respiratory failure, and then they looked at their outcomes. Now, 48 of these patients had diabetes, 145 were non-diabetics. 39 of the 48 diabetics died during the study. So that suggests that, significantly higher mortality rate for diabetics than others. The diabetics were significantly older. They were more likely to be admitted to the ICU, and they were more likely to require mechanical ventilation, more likely to die. These were all statistically significant with very, low p-values. There was also some evidence of differences in inflammatory profiles. So there were statistically significant differences in the labs, such as the WBC count, the absolute neutrophil count, the lymphocyte count, the D-dimer, the LDH, the procalcitonin, the ferritin, IL-2, IL-6, IL-8, and TNF-alpha with pro-BNP. And so this seems to suggest that there's really a difference in the inflammatory profile of diabetic patients as a result of their diabetes. Now, we don't know exactly why that is. Could there be differences in the medications or insulin, and whether those are related to those inflammatory changes? We don't really know. Only 34 of the 48 patients apparently had a medication history available. This wasn't clear in the discussion, but if you looked at the numbers, only 34 had this documented. And there was really no clear differences between those on oral medications, insulin, or dietary control. But I will say that nobody with insulin that was on insulin survived. And there were no differences in the hemoglobin A1C, but again, this is a fairly limited number of patients. So this does add to the literature that diabetic patients are more likely to be severely infected or severely affected with COVID. There was another study as well that looked a little bit more at the specific diagnoses that diabetic patients might have. And so this is called Clinical Characteristics and Risk Factors for Mortality of COVID-19 Patients with Diabetes in Wuhan, China. It was also a retrospective study. And they found that the diabetes significantly, with a p-value of 0.01, showed statistical significance for ICU admission. 7.8% of those without diabetes were admitted to the ICU, whereas 18% of those with diabetes type 2 were admitted to the ICU. And then also the likelihood of developing ARDS, acute kidney injury, acute cardiac injury, shock, secondary infections, and the prognosis, overall prognosis of death was significantly higher in diabetics as well. So again, we don't really understand exactly why diabetics have a higher mortality rate and a higher severity rate for COVID, but it does seem to relate to, in some way, to their inflammatory profile, and that that creates either an inflammatory cascade that promotes ARDS, acute kidney injury, and shock in a way that we don't understand. So anyways, those are some of the studies on that. I want to give Dr. Leung a few minutes to talk about masking, because I know he has a very interesting study that looks at kind of the utility of protective equipment. And so I'll turn it over to him.
Thank you, Chad. Can you see my screen? I'm going to put it on slideshow.
Yes.
Okay, so I'll try to be quick. So I just wanted to thank you for the time. I wanted to make everybody aware that there was an article that came out in the Lancet just last week on June 1st regarding masking. And some of the background, if you've been following the news, actually just a few days ago, the World Health Organization changed its guidance on masking. And you may remember that they were staunchly against masking for asymptomatic individuals ever since COVID started. And some of you may be aware that, in Riverside County, we actually believe we were probably the first county in the country to recommend face coverings. That was at a time when face coverings were not recommended by the state, by the CDC, or by the World Health Organization. And I think part of the reason the World Health Organization changed their guidance is because of this article in the Lancet that was published just a few days before. So this is just a screenshot of that. And the article is called Physical Distancing, Face Masks, and Eye Protection to Prevent Person-to-Person Transmission of SARS-CoV-2 and COVID-19. And it's a review and a meta-analysis. And you can pull the link or Google it. It's pretty easy to find. Again, it was published just on June 1st in the Lancet. And this is just sort of a cliff notes in case you don't get a chance to read the original source. Again, it's a meta-analysis, and it's really of observational data, so it's not a randomized controlled trial. And they wanted to look at what's the optimum distance for avoiding person-to-person transmission, as well as look at the impact of masking and eye protection on the risk of transmission. So they looked at the literature and kind of, focused on 172 observational studies, and from that selected 44 comparative studies. And from that, they were looking at coronavirus data, more recently from 7 COVID-19 studies in the US and other countries, 11 studies that focused on the Middle Eastern Respiratory Syndrome, which, as you know, is a coronavirus, and then 26 that focused on SARS, which is also a coronavirus. And of those 44 studies, a majority of them looked at distancing and masking, and then probably a third of them looked at eye protection. So pooling all of that data together, this is sort of like the summary slide. What they found in their adjusted odds ratio is that physical distancing of at least 1 meter or more, gives you an odds ratio of about 0.18 in terms of transmission of COVID-19, meaning that if you're at least 1 meter or more away, your risk is 0.18 compared to someone who's 1 meter or less than 1 meter in distance. And then you can see the absolute difference sort of below that, 12.8% risk of transmission for the shorter distance versus 2.6% risk of transmission for further distance. So for all of you, who are wondering what's the impact of distancing, I think this actually gives us some, at least a nice place to start making estimates. So similarly for masking, and that really included the whole gamut, everything from N95 respirators to surgical masks to cloth masks. They found that no masking had a 17.4% risk, and masking compared to masking risk of 3.1% risk of transmission. And a lot of these individuals that were observed were in households. So there's actually also a good study from China that shows that the risk of household transmission is typically about 15% when you have a COVID positive individual at home. So again, it may be you need to think about how generalizable this is. In terms of eye protection, it looks like there's a 0.22 adjusted odds ratio. And again, you see a similar drop in terms of no eye protection from 16% to with eye protection to 5.5% risk of transmission with COVID-19. So, for everybody wondering about, kind of the N95 and face mask debate, the evidence is pretty suggestive that N95s do work better and almost consistent with the nomenclature, the odds risk of, picking up COVID-19, the odds ratio is actually about 0.04. With face masks that include both surgical masks and cloth masks, the odds ratio is about 0.33. And so we do think N95s are more effective, and whether that's related to sort of just a tighter seal that's protecting from, droplets, or because there's a component of aerosolization, the jury's still out on that. And then finally, and thank you, Dr. Vercio, for this. This was following a hair salon exposure that you may have heard about a couple weeks ago, where there were at least 2 individuals who were positive for COVID-19, and they felt like they may have exposed up to 140 customers. So of that, I believe about 46 tested, and none of them tested positive. And so, this is not a trial. It's an examination of a potential cluster, but it does, look like, it does suggest that because the hairstylists were wearing masks, that may have helped with decreasing the transmission. And the final slide. I think some of our strongest data actually goes back to cross-country comparison. And if you look at California, South Korea, and Taiwan, which are not dissimilar in total population, South Korea is about the same size, Taiwan's about half the size, and this is from the Johns Hopkins COVID Resource Center from yesterday. You can look at how our cases and our deaths compare. South Korea, which is about the same size, literally has 10-fold decreased number of cases and 20-fold decrease in deaths. And Taiwan, which is about half the size, they should have about 2,300 deaths compared to California if they were at the same rate, and they only have 7. And they have the density like New York. And so, I think 2 fundamental differences are, the way that in which they've sort of applied universal face coverings as well as their contact tracing. So thank you.
Thank you, Dr. Leung. I think we, as a community, have to thank you for your diligence on this masking issue. I know you've been one of the key promoters of that across for our county and getting our county to adopt these kinds of procedures. So thank you for doing that. And that's had a national effect. I think you've seen that proceed nationally after Riverside made that change. So thank you for doing that. All right. I think those are the main studies that we're going to have time for this morning. We hope that this was a little bit helpful for you as you kind of think about COVID and are trying to evaluate the literature, and look forward to bringing you some new content next week. Please send us any questions that you might have. We're happy to tailor this content that we develop based on questions or thoughts that you might have as part of the community that's participating in these webinars.